Let me find out a bit about you. I think there's some PhD students here, yeah? Okay, excellent, well represented. We're going to talk a lot about research, give you a lot of stuff to critique, and some faculty as well. Yeah, excellent. And some clinical providers, excellent, well done. Very important that this work has relevance to you and what you do. Anybody else? Other groups I haven't mentioned? All right, so hopefully there's something for everybody here. What I want to talk about is some of the work that I'm doing right now and have been doing for a period of time. So you'll see kind of the progression of research around patient and family engagement or patient and family experience, somewhat used interchangeably because hopefully the experience is around the engagement, but we can debate that a little bit further. Talking about why it matters and why now in particular. How to measure it, how it affects healthcare outcomes, and then particularly talk about 3 studies around issues of the barriers to patient and family engagement in pediatric care specifically. Emotional proximity, how stress and negative coping styles that parents have can put a barrier to their being involved. How the physical proximity, that either the family can't physically be with the child, or the things that we do as an institution or as staff to prevent parents from being engaged with in their child's care. So those are the focus for the talk. Since this is a research talk for the most part, and we're going to talk a lot about data and theory, I would like you just to have in mind, though, some real life examples, some real cases. So and I'll present 3 different perspectives that are involved in some of this work, and I'd like to, as we go through the lecture, have one of these people in mind, and you can choose which one you want to have in mind. For example, there's a mother who's just been in a road traffic accident. She has 3 children. 1 child's in the PICU at the regional hospital, badly injured. The other 2 children are right and need somewhere to stay. The mother herself has a fractured ankle, so she's injured, and she has no car because it's been totaled. So what would you think might be her main concerns with the care of her child in hospital?
Who's going to be looking after them?
Yeah, who's looking after them? Maybe who's looking after the other kids, those kinds of things. So you might want to have her in mind as we talk about the research and see how the research might inform how we support that mother as she goes through this experience. Another perspective that some of you might want to have in mind is the Children's Hospital Administrator. They've got a big budget deficit they have to deal with. There's been increases in adverse event rates, so they've had more injuries and errors in the hospital, and more patient complaints lately. They have data showing that there's falling staff morale, and there's a new government pay-for-performance standard. So further budget's going to be tied to performance of the hospital, and they're trying to expand their facilities. They've got some funding for expansion. They've planned a new family accommodation, but now one of the docs, physician groups, is trying to take over that space for lab space as opposed to family space. So what might some of their concerns be? You can, balancing perhaps the need for family support versus other needs, things like that. So some of you may be thinking of this perspective as we go through the lecture. And then the third perspective is the PICU nurse who's caring for the child from the accident. And at that moment, the mother hasn't come in yet, is about to visit for the first time. The child's agitated and crying for the mother. The nurse has 2 other patients, and they have a lot of care needs. The unit's short-staffed, can't find the social worker, the chaplain, and the McDonald house for family accommodation is full, and the nurse has been feeling a bit burnt out with work, given all the high acuity needs. Sound familiar? Not here, maybe in America, but not here. So this nurse, what might his concerns be? So be thinking of these perspectives. I always like to try to bring the people that the research affects into the room as we talk about the research itself. And we'll come back to this at the end. So, okay, so let's talk about sort of the scene setting in terms of research and theory. Patient and family engagement is a big buzzword these days. It's I put new in quotations because it's been around forever, not forever, but at least for the last 30 years, which is forever for some of you. But right now it's become really important again, and I think it's been taken to a new level. The American Academy of Pediatrics has come out with a position statement and defines it as having optimal health outcomes being achieved by when family members play an active role in providing emotional and social and developmental support for ill children. So that's how they define it in terms of the role with children. Some of the core concepts that go across the age groups, though, have to do with planning, delivery, and evaluation of health care that are conducted in partnership with patients and families and in collaboration with patients and families. So it's a different, it is a philosophical frame, a way of how we approach health care, not doing to the patient and family, but doing with the patient and family. And the key aspects would have to do with information sharing, not just one way, us telling them health information, but making sure that we learn from the patients and families themselves about what they have to contribute in terms of information about their own health, their own knowledge, their own engagement. Respecting and honoring differences in how people approach health and healthcare and their goals in their life. Partnership around decision making, negotiation. So it's not, we're partnering with you with this decision as long as you do what we think is best. It's actually negotiation when there are differences around what we think might be the priorities for someone's health care as a care provider. And that the care is given in the context of the family and the community in which that person is receiving care. So these are some of the core principles. So why all the buzz and why now? Well, what's happened really in the last, I'd say, decade for sure, is a much greater appreciation and evidence base for how patient and family engagement in healthcare actually leads to higher quality healthcare. And there's some really nice work done across all the different age groups about how you can measuring improvements in safety and in the quality of healthcare. So a lot of this work has been done in adults, but certainly the more families and individuals are engaged in their own healthcare, you can see error rates go down in hospitals. You can see things like infection rates going down because families are, for example, asking that care providers have washed their hands before they come in the room. People that are taking more responsibility for their own health and being part of the decision making, so they're more likely to follow through on treatments and taking their medicines and things like that. So there's a whole literature now showing that the more you can get families and patients themselves involved in their health care, the better the health care, the better the experience for the family, the better the healthcare delivery system, and even to the point of reducing costs. Again, because there's less waste and error that happens because things are mismatched to what families need and want. I won't go through all that literature, but I want you to know that exists. And this Agency for Health Care Research and Quality in the U.S. is a good website to go to find some of the publicly available information, and also the Institute for Patient and Family Centered Care. But you can also, my email's at the end if you want some of the references, I can share them with you. But you'll find now that the research now is turning into evidence-based guidance and actually healthcare standards. So in the States, you've got the Institute of Medicine, the Healthy People 2000, and the Joint Commission are sort of kind of the three big bodies that set standards for healthcare institutions, saying that to practice to the highest standards, you need to show evidence of your patient and family engagement strategy, and that you have to be adhering to these standards in your performance to even get paid. In the UK, NHS has written the family experience into their improving quality document. And you'll find lots of, probably I think in every developed country, there's now a patient engagement strategy in one of the governmental or professional organizations or payment strategies. So it's really trying to get from the research into translate into practice. But at the same time, it can also be lip service, if you will, that we can talk about it, but somehow between the talking about it, the standards, and the actual practices, things don't always match up. So in the U.S. And to a lesser extent in Canada, the U.K., and Australia, they're starting to put measurement systems in place and monitoring systems in place to see that hospitals are actually, and hospitals and all healthcare organizations, so through to outpatients or extended care facilities as well, are starting to measure and show evidence that they're engaging families and that the experience is a positive one for families. And the U.S. Has taken it to, I think, the farthest level in that payment now through the Medicaid system, so the public insurance system is using these patient experience surveys as part of the calculation and as part of the payment scheme. So that's really got everybody's attention because you have to show that your hospital, your health care institution is delivering a high quality patient experience, or you'll get paid less, you'll have less resources. So it's really, as I say, got everybody's attention. And the pediatric survey is coming out sometime in this next year. I don't think it's going to be tied to payment for another year or two. It's coming to the pediatric world shortly. So do you know in Northern Ireland is, I think you're doing the surveys, certainly in adult care. I think in pediatrics it's done on a 2-yearly cycle, and I don't think it's tied to payment at this stage. But you might keep an eye out that it might be the wave of the future. We'll see. If the U.S. experiment turns out not to work, it may not. But I think what's important to know, because sometimes, again, and sometimes from the clinician's point of view, or certainly you hear physicians talking about it, because sometimes their pay is tied to their performance, as part of the hospital system, that there's disparaging remarks that it's just about satisfaction, patient satisfaction, and it's a popularity contest. And I just want to take a minute to point out that the work around patient engagement and the measurement of patient engagement has really moved on from just satisfaction surveys and whether families didn't like how much it cost to park or what the food in the cafeteria was like. Really has moved on from that. And there's again a large research body on how to measure this. And these are the main dimensions that are being looked at. And as you can see, it's fairly sophisticated and does really try to tap into all these different dimensions around engagement and the experience of care. And tapping to the core principles that I mentioned earlier. Now, we can still, however, debate the rating scales and the appropriateness for patients of different literacy levels and all those kinds of fine points. But I think it's definitely moved on from patient satisfaction surveys that people talk about. And again, I think I mentioned, tapping back to the issues around why it matters to hospitals in terms of safety and quality of care, it also affects at the individual level healthcare outcomes. And there's been some other interesting work that, in fact, it can lead to, good engagement leads to faster recovery, and also things after the healthcare episode, like, post-traumatic stress symptoms, things like that in the longer-term care. So not just at the institutional level, but at the individual level, engagement has longer-term effects. I mentioned adherence earlier. It would be another one you could put in that bucket. So I just want to give you sort of a visual of how it all connects. Okay, now, talking specifically about pediatrics, you know, we all, you know, I think know, and I'm probably preaching to the choir a little bit, that parents, you know, want to be engaged in their child's care for the most part, and you know, but it's taken us a long time to kind of get the parent not just to the bedside as a passive bystander, but as an active partner in care, and we're still facing some challenges about that, and that's what I want to focus on in the talk. We've sort of gone from a place of excluding parents by either philosophy and policy, like, you know, in the 40s and 50s, in kind of the era of modern hospital care, where parents were, you know, banned from being in the hospital because it thought that they brought infection or made children more distressed. We've sort of moved away from that to, you know, allowing and then encouraging and inviting parents to be participant. But in fact, in some ways, we've created a scene where, you know, they're still excluded because we've got so much technology. There's not a room, you know, there's no place to put a chair, much less a bed for the parent to stay overnight. So, you know, even though we say, and we have a philosophy of wanting the parent to be engaged, we actually have excluded them because of the physical environment. So I just want to point that out, how the, you know, the messages come across might be counter to what we think we're saying for families. So I would call it at this stage, although we have a philosophy, although we have, you know, some evidence, although we have ways to measure, we're still at a stage where we're a work in progress. And these are just a couple quotes from families from our studies talking about some of the different difficulties they encounter in terms of, you know, worrying about their other child, or, you know, actually the physical reality for them of trying to be in the hospital caring for their child. So let's go through these different barriers, the three ones that I mentioned, and just talk about some research around each of those. So the first one is the difficulties with emotional proximity. So we can get the parent to the bedside. Maybe we can even clear a space and put a chair or a bed for them to stay overnight. But if the parent themselves is experiencing a lot of distress, they're not going to be emotionally available to really be a true active participant, to absorb anything that they need to learn, to be able to engage appropriately with their child. So we really need to figure out how we can better support them or understand what their distress needs are so that we can help them to then be there and truly engaged in their child's care. So the first study I just want to talk about is a study where we tried to look at what the effects of stress and some of the contributors to parent stress were for children who are hospitalized on the general wards. Now, we know from probably 2 decades of really good research that parents who have children in pediatric intensive care or children who have cancer have a lot of distress, certainly suffer from post-traumatic distress, and that there's a strong link between what goes on for those parents and how their children recover, because if the parent has a lot of stress and post-traumatic stress symptoms, anxiety, depression, hyperarousal, things like that, the child will also experience added distress, and that will affect their recovery. But what we wanted to look at is what would happen and what's the experience like for parents whose children are hospitalized on a general ward for things that we would call routine as a clinician. You know, maybe the child has a chronic condition, maybe an acute condition, but that they're not requiring a high level of intensive care and are on a general ward. So this is work we did with the Children's Hospital in Oxford, and we surveyed 107 parents who completed questionnaires while they were in the hospital. And we specifically asked parents who were staying more than whose children were staying more than 3 nights, so that they were slightly longer admissions, and we could really get a sense of what their hospital experience was like, because they had a longer exposure to the hospital. And after they were discharged, we again sent them by post another set of questionnaires to ask them about their experience after the hospitalization. And we measured a whole range of things, all the things we knew from the literature, from PICU families and children with cancer, things that might influence their experience, such as their baseline anxiety and distress levels, their coping styles, what kind of social supports they had, other things. And then we measured at 3 months, we used an instrument that measured post-traumatic stress symptoms, as well as the child's health status, any other events that had happened in their life that might cause stress afterwards, but had nothing to do with the hospitalization, things like that. So they had a whole battery of surveys that they completed, and we did some regression analysis to try to look at things and see how they all related to each other. So the first thing we found, which sort of astounded us, which is that after, again, what a clinician might call a routine hospital admission, just about a third of the families reported some post-traumatic stress symptoms 3 months after their child had been discharged. And we thought that was, quite substantial and really unexpected. And it was comparable to families of children who'd been in the PICU or children with cancer. Again, there's an expectation from people who work with families every day that, these distress symptoms in families relate to the level of illness that the child has. But in fact, what we're showing is that it's not. It's related to the hospital experience itself, regardless of how intense the child's illness is. And almost a fifth of the families, 21.5%, had scores that were consistent with the diagnosis of post-traumatic stress disorder. So even more severe symptoms that actually would impact their life and their ability to function and to parent. And this is from the regression analysis, the model that shows how the different factors that we measured related to or predicted a parent having post-traumatic stress symptoms. And of all the things we measured, not everything is shown on here. These are just the ones that ended up being significant. So it had to do with the length of stay, so the exposure to the stress, how long the families themselves were exposed to the acute stress of hospitalization, were more likely to have stress symptoms. The child's health status afterwards, so we had to control for that, because if the child had ongoing illness issues, that was an additional stress burden on the family, and again continued to expose them to stress, and they were more likely to have symptoms. Single parents, so a parent with perhaps less social support, having the full burden of parent responsibilities, was more likely to have that. And parent anxiety and depression were also influences, although there was an interaction between that, which I'll explain in a minute. But then what I want to point out is uncertainty, parent uncertainty, which I probably shouldn't even have it titled that, but that's the name of the instrument. But what that parent uncertainty measure really measures is the parent communication with the clinical staff. So it's things about how much information did you get, were you getting consistent information from the various care team members? Did you know what was being planned for your child's care? Things like that. So it's more uncertainty about their treatment as opposed to uncertainty about whether the child's long-term prognosis, for example. So that was a big issue. And then negative coping styles, so how a parent approached stress in general. So, and the three that really were the ones that were most significant were denial, self-blame, and venting. And this is, I think, really, really interesting, because what I meant to say is that anxiety, if parents had anxiety and these negative coping styles, then they were more likely to have stress. if they had depression and these negative styles of coping, there wasn't as much an effect. They operated more separately. So it's sort of a technical statistical issue, but it just shows the interaction between anxiety and these and depression and these styles that might confound the results. So it's something that we just have to look at when we're doing measurement or screening. But I think the main message is that knowing that these are the things that can influence whether a parent is going to be at risk for post-traumatic stress symptoms after a child's hospitalization, we can start thinking about ways that we might screen families or help families with trying to reframe the experience and maybe develop some different coping styles. So we could use the hospitalization as an opportunity to teach parents new skills perhaps and new ways of thinking about it. So it doesn't have to be just something that we observe and say, oh well, there's nothing we can do. So from this work, we concluded that certainly we need to pay attention to what happens to parents after their children leave hospital, that we can't just leave it there, knowing that almost a third of them, just by virtue of having had a longer term exposure to the hospital, might be at risk for these symptoms. We can't just send them off and say bye-bye. We need to think about what kind of follow-up supports are out there for families. We also need to look at what we can do while they're in the hospital, as I say, to think about helping them gain some new skills or identifying the ones who are at particular risk that may need some psychological or social support intervention while they're in the hospital. And then we need to think about, again, new strategies for how we prevent this. And there might be some things that we can do as clinicians, as educators, to better prepare parents and children for hospitalization. So I'll just keep going if you don't mind. We can talk about questions at the end. I'm sure hopefully you'll have something to say about each of these. But let's just move on to, so we know that we need to think about how parents can be more emotionally engaged with their child and be more involved in their care. But we've also got the physical challenges. And the first one is just the physical proximity of getting the parent to be at the bedside with the child. And there's a lot of barriers that we've known about for a long time, but it's astounding to me how little measurement there's been to really identify the magnitude of the problem and what we can do about it. It's all been really kind of haphazard, how support services for families and our efforts to get families and children to be together, to be involved in their care have been just so, really haphazard. But some of the factors are distance from home, being transferred to a referral center like the mothers in the case that we started out with. Lack of accommodation, I've mentioned already, but can be a really big problem. We were talking about it just before the lecture as a local issue right now. And we really have little evidence about how best to support families when they're there. Is it just about giving them a bed in the room so they can be there, or do we have to do more to help them engage, to give them the support they need, to teach them how to be effective advocates and caregivers and decision makers in this very foreign setting to them? Those are some of the questions and challenges. Right now, many hospitals provide some type of accommodation service and say, yep, we have it. But when you dig a little bit deeper, you find out that maybe it's a reclining chair at the room, in a really crowded room with lots of other equipment, maybe other patients, other parents. Maybe it's a room down the hall, a converted patient room that they could maybe camp in. Maybe if they're lucky, there'll be some purpose-built accommodation. And if they're really, really lucky, there'll be a click sergeant house for children with cancer, or parents of children with cancer, or Ronald McDonald House, or some other kind of family accommodation that is really geared around not just giving the parent a place to lay their head, but providing peer-to-peer support, other volunteer support, some food, assistance with the costs of being away from home, a place where the siblings can come, a place where the grandparents can come, that the family can be together. But that really is the exception and not the rule. So what we wanted to do, and in partnership with the Ronald McDonald House Charities and the National Research Corporation that does a lot of these patient engagement surveys, we wanted to find out on a bigger level what was going on across the United States with regard to family proximity and parents being able to be near their children. So we conducted a large-scale survey to find out where do families stay. There was some interest, some work early on about care by parent units and parents being at the bedside in the 80s when it was still sort of a new concept. But since then there's been very little published around what supports are available for families and how families use accommodation to be near their children in hospital. And no one's ever really looked at sort of the interactions and some of the relationships between family accommodation and their perceptions of their hospital experience. So we wanted to take it that next step further. So these were our research questions, and we looked at these patient experience surveys, the surveys that I talked about in the beginning, and just looked at the very high level measures, the overall experience rating. So what, if the global rating of what a family said, did they have a positive experience or a negative experience with their child's hospitalization? Would they recommend the hospital to a friend? That's a really good question. If you want to get at their opinion of their experience. And another question which we added, which is about enabling, did the hospital accommodation actually help the family to be more involved in their child's care? We added that specific question. So we took the standard national survey and we added 2 questions. And the usual process is that after discharge, the questionnaires get mailed out to the families a few weeks after the discharge. And we did logistic regression, looking at the effects of the accommodation type, plus some other variables that are measured in the survey, like information about the family, distance from home, and some, information about the hospital, like whether they had a Ronald McDonald House or not, and some things around the child, their age, their gender, length of stay, things like that. So not as full a battery as in the first study, but what was available from these national surveys, we looked at those factors, because this was, again, just a first exploration to see whether accommodation really made a difference in the hospital experience. And here are the 2 questions that we added. First of all, to find out where parents stayed. And these were all the types that we could think of, and we vetted these with clinicians and parents to see if they represented the full range of where parents might stay when a child is in hospital. So we asked them to answer that question, and then we added the question about involvement, and did ask the families to rate whether having, whatever accommodation they had, did they have a perception that it had any influence on their ability to be close to their child and involved in their care. We had invited 49 hospitals because they all use the same survey instrument. 10 accepted the invitation. The others that didn't were doing some other kind of major initiative at the time, like trying out the PEDS CAHPS survey and things like that. So it wasn't, we think it's a fairly representative sample. There were some urban hospitals, some that were a little bit more rural. 6 were specialist children's hospital, and 5 of those had a Ronald McDonald House associated with it. 4 were general hospitals, but they had large pediatric services in them, and no Ronald McDonald House, and a wide variety in terms of the size of the hospital, and a wide variety in terms of the population they served, in terms of how much, private versus public insurance. We got just over 5,000 surveys returned in the time that we ran the survey. And there were two different versions of the survey. I'll just really talk about the inpatient version, which included the general wards and the PICU. There was a small proportion of the sample that completed the NICU version, and we had some interesting results from that, but it's a much smaller sample, so I won't really talk about that. And the response rate was about 12 to 30%, which sounds a bit low, but is actually quite average for these large national patient experience surveys. And so again, we felt that it was representative of the sample or of the population. And so first of all, it was just interesting to find out some things about families that go to children or have children in hospital. The age range was fairly spread. Obviously, a lot of children that end up hospitalized tend to be younger. The children are most vulnerable in the first few years for serious illness requiring hospitalization, so that's fairly representative. But we had about 20% that were in the teenage years, so that was interesting. Most of the surveys came from the big children's hospitals, and that's just because they saw the most volume and throughput, so we had a sort of an overrepresented representation, if you will, of the large children's hospitals. Length of stay, again, most of the children were there for either very short hospitalizations, which reflects current practice. A lot of things are come and go for surgery now, and very short stay, and parents then caring for children at home. But then a large range, some kids then having very, very long stays of more than 3 weeks. But this was interesting. Travel distance, over 60% were local or relatively local to their hospital, but we had 11% traveling over 100 miles, being referred to a specialist center, for example. So a broad range of diversity there. And we found out for the first time, I think ever, where families stay overnight. And this was one of the interesting, this is one where I do show the difference between the pediatric inpatient and the NICU population. With most of the, if you look at the dark blue lines, the pediatric inpatient families, most of them stay with the child in the child's room. And they're just, at the bedside. That's the majority. And the next most common would be at home. And that makes sense given that over 60% live within 25 miles of the hospital. And then lastly, it'll be the Ronald McDonald House would be next at, 4.4%. But those tended to be the ones that had the longer length of stay or that traveled the farthest distance. So they're serving a very particular group of families. Whereas the NICU families had a very different pattern, with about half of them staying at home and over 25% staying in the Ronald McDonald House. But when you think about it, there's really no room at the bedside in the NICU for a family to stay, right? They're just physically, some hospitals now in the States are moving to single-family NICU rooms, but for the most part, they're still multi-bedded rooms with cots and not room for the family, so they need to stay somewhere else. And so, but this has now been documented, and we can look at the impact of those different patterns of accommodation. When we looked at the three different ways of measuring the overall experience, what we find was, and we just did just some basic correlations, we find that in fact the Ronald McDonald House families had a much more positive experience of the hospitalization on all of the measures than the families that stayed in the other accommodation parts. And I was a bit surprised by this, because I actually thought the families that stayed in the hospital room with the child might have the more positive experiences, being the most close as they could possibly be and perhaps the most involved. But maybe it is more about some of the other services and supports that they receive that helps them to better cope. But we'll explore that a little bit more. But this is just the unadjusted without taking into account any of the other variables like travel distance, length of stay, or any of the other things we were able to measure. But the other thing we learned is that, what does make a difference to overall hospital experience? Some of the other things that we measured really did affect them, and we ended up needing to control for them. So things like lower child age, the less healthy a child was, the less positive the family's experience was. So if your child's more sick, you're going to have a less positive experience. If your child's younger, you're going to give a less positive rating. The more highly educated families gave less positive ratings. And non-English speaking families gave more positive ratings. And certain hospitals had very different patterns of their experience. So these were things we had to control for. Things that didn't make a difference to the hospital experience ratings were how far away they lived, how long the child was in, the parent age, or things that we could measure about the child, like whether they had special needs or their gender. So we didn't include those in the regression analysis. But I think it's interesting to note that we didn't see those relationships. And then this shows the after adjusting, so taking into account those things that influence the ratings of their experience. When you put that all together, we show again the similar pattern to just the unadjusted, which is that the families that stayed in the Ronald McDonald houses and had that more wraparound, as I call it, support system for them, had more positive experiences. It's tipping down out there again. Than the families that stayed in the room. So having, whatever it is about that other, maybe having a bit of respite, maybe having the support services, you're nodding, made a difference versus the families that were right there in the room with the child. They had a less positive experience, and even less positive with the ones that stayed at home with maybe their own support structure. So this is for their overall experience. You see the same pattern when you look at what they recommended the hospital to a friend, and you see the same pattern again on the accommodation helpfulness, and even more skewed. So that's again, more positive scores for the RMH. So we think this is all terribly interesting. I hope you find it somewhat interesting, at least. But for the first time, we now have a sense of where families stay and what different types of accommodations they use when their child is in hospital. And we saw variation, in their overnight accommodation based on their characteristics, and that needs further exploration. Why do certain types of families, choose or have different options for staying in different accommodations? And we now, for the first time, see that there's a potential for a linkage between their overnight accommodation and the effect on their experience, and potentially on their engagement and involvement. And with this particular finding about the Ronald McDonald House as having more positive experience and involvement. So we need to pursue this further. So we think that the further research agenda would be around looking at demographics and clinical factors in a more broad way, because we could only measure a limited set from the existing survey. And really, we need to start measuring what's going on with families, how far they're traveling, what is the real availability, are there waiting lists for these accommodation facilities, do we have enough capacity? What's going on with families in terms of needing to care for other children or having older family members that they're caring for? How much does employment and transportation constraints, and I need to add in here insurance for American families, because they're really burdened by needing to maintain their health insurance through going back to work, and then aren't available to be involved in their child's care because there's a limited public insurance system. So these are things that are going unmeasured, but we really suspect have an impact on families' ability to be involved in their child's care and be engaged in their child care. In terms of the health service, we need to look at opportunities for meaningful family involvement, and we need to, again, start measuring this and looking at it as if we're going to be comparing hospital experiences across hospitals and in payment schemes, we need to start adjusting for these covariates. So really quickly, just one last study to go through, and then we can kind of put it all together and have some discussion. But what about when we don't encourage or we have policies or things that limit family participation? So it's not about the family physically getting to be there, it's more about what we do to not support them, if you will. And this is a picture of a typical NICU, and oftentimes you don't see a lot of families there because, again, do we allow them or do we make them feel unwelcome or do we not have a space for them? So this was a part of an analysis that came from a study that I did in 4 hospitals in London, where we looked at how parents felt supported by the staff, by the physicians and by the nurses. And we also surveyed the nurses and the physicians to see how well they thought they were doing in terms of supporting the families. And the survey tool we used, called the Nurse Parent Support Tool, wasn't just about emotional support. It tapped onto other dimensions of support, information, and also physical supports, what we call instrumental support. So did they help the family to be involved and be part of the child's care or the baby's care? And what we found was that, luckily, hopefully, we found that parents, some or most of the time, felt that they had support for nurses. Now, it wasn't always, which would have been nice, but it wasn't none. So it was some or most of the time on average. And parents were influenced by their NICU experience, and I won't go into that, but the relationships, and again, what parts of the family's experience influence their perception of support by nurses, I think is a really interesting area to pursue. But what's interesting is that nurses thought they were giving support to the parents almost always, and I'll show you that in the next slide, the difference between what parents think they're getting from nurses and what nurses think they're giving to parents. Physicians, on the other hand, had a lower rating of their support to families, and it wasn't so much that they didn't think they were doing as good a job, it was just around a more limited set of support aspects. So they didn't see that they had much to do with providing the instrumental support, helping the family with daily life issues. It was more around information support, so they had a much narrower band where they thought was their responsibility. And so they didn't do the whole breadth of all the different ways that parents might be supported. But here's the most interesting thing when you look at how the nurses, and so this is on a 5-point scale, and the nurses gave themselves very high ratings for supporting families. But if you look at the parent ratings, they're all across the board in all the different dimensions: emotional, information, appraisal and esteem, instrumental, as I mentioned. They all rated the nurses much lower, and that we need to explore that. Is it that there are certain nurses that are doing really well and others that aren't doing, so it kind of balances out, or is it everybody doing not as great as they could be in meeting the parents' needs? And do we really know what parents need so that we're actually making sure that our supports match? So we need to really look at what we can do and more critically reflect on, do we really know what parents need to be active and to be engaged in their child's care? And are we matching that some of the time, most of the time, and what about the mismatch? And how can we better attend to that? So I'll leave you with that thought and just wrap up in terms of coming back to our 3 individuals. So thinking about the research and what we've shown, going back to the mom who's trying to balance the challenges of her very sick child, her kids at home, her own health, her lack of transportation, how does she negotiate these systems and get the supports that she needs? What about the hospital administrator who's trying to create a system that supports health, but again, not having the resources or having to choose where to put resources towards families, towards generating revenue, towards staff supports, things like that. And what about the poor PICU nurse who's trying to, do something, with the urgent physical needs of the child, plus trying to help with the emotional support and get the family to be involved, because that's what they believe in based on their nursing education. What could we do differently to address all of those things? Some of the things that I think wouldn't be too hard to do if we were a bit organized would be to have some way to prepare parents a bit better, parents and children, about what they might expect, help them engage before the situation, screening we've mentioned, and teaching positive coping strategies when they're in the moment. These are things that could be done. In terms of the physical proximity, we really have to do some lobbying and be more creative about finding the resources to provide the physical opportunities, and then helping families understand how essential they are, so that they maybe would make a bigger effort to try to be there for their children if they really understood how essential they were. And then lastly, again, advocacy and policy needs to be addressed, looking at ways to help the administrators make different choices by showing them their hospital ratings or showing them how it affects safety and quality, to have a better patient experience and better engagement. And again, helping the frontline staff to appreciate how essential families are to the children's recovery might, again, help people stay more engaged, not be so burnt out, and try harder even in the difficult circumstances. So I'll leave it there, and we've got a few minutes for your reactions and thoughts about the research and the clinical realities, and I very much welcome your comments. Thanks.